The FDA just removed the black box warning after 22 years. What does this mean?
It is going to take away some of the fear and the panic that has been associated with hormone therapy.
You'd think doctors would celebrate. Instead, they're more divided than ever.
So when you look at the clinicians that trained after 2002, they are going to be very hesitant, very fearful, because that one study really defined their understanding of menopause and what we could do for a woman.
We've got top gynecologists who are looking at the exact same studies and reaching completely opposite conclusions. Some say hormone therapy prevents dementia and every woman should be on it. Others say that's dangerously overselling benefits we can't prove, and we're setting up the next medical crisis.
Black box warnings are meant for dangerous products like
cigarettes.
Yes, things that could be life-threatening. This isn't cyanide, this is estrogen.
Today's guest is Dr. Mary Claire Haver, board-certified OBGYN, Menopause Society certified practitioner, New York Times best-selling author with over 3 million followers.
To this day, there's not been a single clinical study, large scale, on the treatment of perimenopause.
That's insane. Is this also the period where a lot of women are getting prescribed SSRIs?
Yes. I was taught that women tend to somaticize psychological issues. So if you can't figure out what's going on with her, it might be in her head.
She's at the center of this war, and we're going to find out why smart doctors can't agree on what the science actually shows.
All vaginas need estrogen, all of them.
This is central to your argument of why women should be at least offered hormone replacement therapy.
At least have the conversation.
I'm Louisa Nicola, and this is the Neuro Experience podcast. Dr. Mary Claire, I'm so happy that you're here finally.
Thanks for having me.
Let's start with the huge announcement yesterday. The FDA just removed the black box warning after 23 years.
2003, so 22 years.
22 years. What does this mean?
First of all, I think it's a wonderful thing.
Yeah.
And that it is going to take away some of the fear and the panic that has been associated with hormone replacement therapy. So in my clinical practice, I sit down with a patient, we go over her risks and benefits, and we decide she needs vaginal estrogen for her genital urinary syndrome of menopause. She goes to the pharmacy, picks up this FDA-approved medication. It's $15. She's so excited, opens the box, pulls out the paperwork, and sees a very large black box warning that says she is at danger of stroke, hypertension, dementia, a laundry list of things that had absolutely no scientific basis for a local vaginal estrogen product. She's terrified, calls me in a panic.
Mm-hmm.
About a third of women who pick up these prescriptions never use them.
Mm-hmm.
And we think it's because of this boxed warning, which is not really based on modern scientific evidence, especially for the local vaginal products. So removing that and allowing that conversation to happen between a clinician and her patient really, I think, is going to allow women to have the confidence and lose some of the fear around these products.
Because prior to the Women's Health Initiative,
there was no warning.
There was no warning.
Mm-hmm.
No. And
just the normal contraindications and normal warnings, but not this black box warnings are meant for dangerous products like
cigarettes.
Yes.
Yes.
Things that could be life-threatening. This isn't cyanide. This is estrogen.
Exactly.
A natural hormone that our body produces.
So currently the percentage of women taking HRT is what, 4%?
4% of FDA-approved products.
Yes.
When we add in compounded, which isn't tracked, through a national database. So we're guessing maybe it's 7 to 8% when we add in compounded. So still well less than 10% of women who are eligible.
That's going to make a huge difference.
We hope so.
Okay, it was just announced yesterday.
Mm-hmm.
So what's the time?
So hopefully we have to get the clinicians on board, because remember, in order for a woman to get a prescription, she needs a licensed clinician who is willing to write the prescription. Then she has to go and get it filled. So one of the big stopgaps is we have a whole generation of doctors, nurses, nurse practitioners, anyone who has clinical prescribing privileges who were never really trained on how to properly prescribe or counsel patients for hormone therapy because of the fear surrounding it. I think, honestly, we're about 10 to 15 years before this is a normal, natural part of practice. That is just the trickle-down effect of when these changes happen and how long it takes. Now, I do think social media tends to speed things up, and we're seeing that clinically, where women are really turning to social media, good and bad, to educate themselves and then going to their clinicians. Clinicians are using social media as well to get some education themselves. But as far as for the regulatory boards and the education system, I think we're a good 10 years out before this is common clinical practice.
That's insane. How many more women are going to have to be denied hormone replacement therapy in that time frame?
This is huge, but it's still going to take time.
Okay, so we're seeing a huge divide between, you're a board certified OBGYN. When it comes to social media, you yourself just said, we're getting a lot of our information, good and bad. And I do agree, from social media. It's free education, right? I get tens of thousands. I know you've had 10,000 messages, I believe, just about frozen shoulder.
Yeah.
So women want advice, but where to go? And then there's this huge divide between OBs even. One say that hormone replacement therapy is very efficacious and we need it. It's going to be preventing cardiovascular disease, dementia, all of the symptoms associated with menopause. Then there's this other OBGYN, also board certified, who believes that we don't have a robust amount of studies to suggest that it is efficacious.
It depends on when they trained. Clinically relevant menopause care is not a regular part of the OBGYN education curriculum. Not, and I know this because I was a former residency program director, so I knew the curriculum backwards and forwards. And it is an afterthought at best. We have a few vignettes that we might talk to the patients about, but it really depends on the program if there's even a menopause clinic.
Yeah.
So routine, regular, evidence-based, like sitting in a clinic across from, dozens of menopausal patients doesn't happen in most programs. I didn't even know the Menopause Society existed until about 3 to 4 years ago, until I really got into the menopause space. I thought I knew everything I needed to know. Board certified, I get recertified by the American College of OB-GYN every year. When I go to take my recertify from my boards every year, there are several divisions. There's gynecology, there's office practice, there's surgery, there's OB, high risk OB, there's ethics, there's genetics. There's not a menopause category even. Still. So it's just something that hasn't been prioritized, and it depends on when the doctor trained. So if you look at someone like Sharon Malone, Lauren Stryker, the doctors who were out in practice before 2002, all of them were trained on how to give hormone therapy. There was no black box warning. It was a normal routine part of their practice, and something that most of them have continued to do despite the WHI. They have some more nuances in their counseling. We've learned a lot from the WHI, and I don't want to demonize that completely. But then you get to someone in my generation where I graduated with the WHI. That was the same year. And it dramatically changed how I was thought, what I thought about menopause and how to practice medicine. And then everything after that. So when you look at the clinicians that trained after 2002, they are going to be very hesitant, very fearful, because that one study really defined their understanding of menopause and what we could do for a woman. So it really just depends on when they train. Now, I think that the ones coming out now or are starting now are going to have a completely different experience.
Let's go actually back to residency, because I know that you said something that really changed your life when you were sitting in front of a menopausal woman. She was describing her symptoms, and I think it was your residency director, or maybe
it was a chief resident.
It was a chief resident that used the 3 Ws.
I was an intern. Now, this is before WHI. Okay. So this is more about how women were perceived and what. So I was taught that women tend to somaticize psychological issues. So if you can't figure out what's going on with her, it might be in her head.
Yes.
Or as the wonderful Dr. Elizabeth Coleman quotes, bitches be crazy. So in her book, it's like the best chapter. So here's the clinical example of this. I'm a new intern. I'm so excited. It's my first day in gynecology clinic. We have a hierarchy of training. So the upper levels are really wanting to get their surgery numbers. So they're running to the pile of charts and they go through and they try to find the surgery cases first. So, because they need their numbers and they want to operate. So boom, all those charts disappear. Then the next level residents go in and they grab the procedures, the colposcopies, the polypectomies, the things where they have to do things with their hands because it's fun and you want to get your training. And then the interns take whatever's left. So I pick up a chart and it's a patient in her 40s. She was Caucasian. She had had a couple kids, wasn't trying to be pregnant. I think she'd had a tubal ligation. So pregnancy was, not an issue on the table. And she had multiple vague complaints. She was tired. She was gaining weight. She was suffering a little bit with depression. Her libido was waning. She had some aches and pains. So I'm flipping through the chart and she'd seen 3 or 4 doctors before she got to us. Basically, she'd been shuttled through different specialties. People had checked her thyroid. They'd done some basic lab tests. So my upper level comes up and he's like, what do you have? So they're in charge of us, right? So I'm like, and you have to do your presentation. So I'm like, I have Miss Smith, and she's a 45-year-old Caucasian female who has the following complaints. They check her thyroid. And I said, yes, sir, family medicine did. And did they do this? So she had the basic lab tests. And I said, basically a normal physical exam. I'm not sure what to tell her. And he goes, sounds like you got a WW. And I didn't know what that was. It's new terminology to me. What's that? And he said, don't write this in the chart, but it's what we call a whining woman.
Oh my God.
Okay. He said, women at this age tend to come in with lots of complaints. And if their labs are all normal, there's not much we can do for them. Pat her on the neck, pat her on the knee, tell her to get, take some vitamins, tell her to get some more rest, tell her to, have a spa day or whatever. And this will pass. I took that as the truth. And I have to be honest, I'm of that mindset at the time. I'm lucky to be here.
Yeah.
I have total imposter syndrome.
You're in your probably 20s at the time. So
I'm 30.
30.
I'm 30.
Okay.
And I'm younger than her, right? I haven't gone through this yet. And I'm just like, okay, women tend to go through this. I'd already been taught women tend to somaticize psychological issues. So maybe she's a little bit depressed or something, but never that this could be the onset of her perimenopause.
Yep.
All we learned was how to pronounce perimenopause. There's to this day, there's not been a single clinical study, large scale, on the treatment of perimenopause.
And correct me if I'm wrong, is this also the period where a lot of women are getting prescribed SSRIs?
Yes.
Optimizing your brain for peak efficiency should be at the top of your mind. It's literally what will keep you thinking clearly, reacting faster, and performing at a high level. One thing I have been experimenting with is Transcription's methylene blue. It's these small blue lozenges that dissolve in your mouth, and it's actually called a troche. And what it does is it supports mitochondrial function, those little power plants inside the neurons that produce ATP, which is your brain's energy currency. When your mitochondria are working well, your neurons communicate faster, your focus lasts longer, and your brain feels more alert but calm. I take this almost every second day just to feel at my peak. You've probably seen people using this and walking around with blue tongues. It's called methylene blue. It's a nootropic that helps your brain perform better. So you can obviously have a better performing brain as you age. If you want to try this, go to transcriptions.com, use code NEURO to get 10% off. They also have one for nighttime, which is more of a calming effect. That is transcriptions.com, code NEURO for 10% off. By far, the latest supplement that everyone in the longevity space are talking about this year is urolithin A. And urolithin A is found in MitoPure from Timeline. And so many people are taking them in the gummy form or even in the supplement form for better regeneration of their cells. So MitoPure contains urolithin A, which is being clinically proven to help your body renew and repair mitochondria, essentially upgrading how your cells produce energy. The impact is subtle, but it's real. You get better recovery, more stable energy throughout the day, and sharper focus, especially when you are working long hours or training super hard. It's one of the few products that's backed by serious science and actually works at a cellular level. If you want to try this, go to timeline.com/neuro to get 20% off and start supporting your energy from the inside out. That is timeline.com/neuro for 20% off.
So we see premenopausal, the average prescription practices are about 10% of women are on an SSRI or one of the antidepressants, right? Across the menopause transition, that doubles to 20%, doubles. Then by the time you're 65, it goes up to 25%.
Oh.
With no discussion of where hormones or the changes in our hormone levels might be playing. Now that is changing. I'm seeing more articles day by day looking at the connections between hormone health and mental health. So I think we're getting there, but we have a long way to go.
And look, I think it's also bidirectional, right? Instead of just thinking about, well, what role does estrogen play in mental health disorders, psychiatric disorders. I think it's also women are complaining, let's just say, of sleepless nights, insomnia. So they're actually being prescribed not Ambiens. I'm seeing people getting prescribed amitriptyline, which is a tricyclic antidepressant, which in low doses can help with sleep, but it's also an antidepressant, right?
I think it all feeds into each other. But when we strip it down and look at the root causes, there's environmental. So a lot of women are going through aging parents. raising teenagers, raising kids, troubles in their marriages. It's a difficult time of life for women in general. But what I see in my clinical practice is my patients are coming in and they know their stresses, and they've had them managed. They were like, look, I've got the angry mother-in-law, or I've got my dad is in, for example, assisted living, I had this managed. Nothing in my environment has changed.
Mm-hmm.
I have changed, and I am struggling to have resilience for the life I built for myself. And that's the patients where I feel like I'm helping the most.
Now, do you find that there's also a misread? Because I remember in my early 20s, obviously far away from perimenopause, or there were some days where I was agitated, sleepless nights, going through, you go through med school. How do you differentiate the symptoms?
What I do in clinic is, because we don't have a great blood test for perimenopause. So how could we possibly know? There seems to be for most women a constellation. And the first symptom, there's a great, beautiful study, and they just presented this at the Menopause Society meeting. I just don't feel like myself. And you have to sit down and listen to a woman and believe her when she tells you what's happening. It's almost universal that they're like, I just don't feel like myself. And it could be mental health. It could be cognitive changes. So she's struggling to find her words. She's not able to complete tasks like she used to. She feels like she's developing ADD. Some of them, in the most severe cases, really feel like they're developing dementia. She's having sleeplessness all of a sudden, where she used to be a great sleeper. Not a woman who's always struggled with insomnia, but these struggling to go to sleep because of racing thoughts, that's new, or those 2 a.m., 3 a.m. wake-ups without anything really changing in her environment, struggling to process alcohol the same way that she used to. So many of my patients are just ditching alcohol altogether because they just aren't tolerating it. That celebratory glass of champagne, you're paying for it on the other end much more than you used to when you were younger.
Let's talk about that, the timing hypothesis, or the critical window. This is central to your argument of why women should be at least offered hormone replacement therapy.
At least have the conversation.
It's the critical window, which is important, but I'm not sure. Do we have proper RCTs on this window yet?
The biggest RCT we have for hormone therapy is the Women's Health Initiative. Okay. And it was a randomized placebo-controlled trial that looked at no hormone therapy versus, and 2 very specific formulations, Premarin if you didn't have a uterus, or Prempro if you did. And then they followed these women for decades, okay? They were on for 5 to 7-ish years.
Wasn't it conjugated?
Conjugated equine estrogen,
yes.
Which is Premarin.
Yes, okay.
A very specific form of estrogen that actually comes from pregnant mare urine, which was a very rich source. But it contains multiple different estrogen compounds, not all found in humans. But that was the number 1 most prescribed estrogen at the time. So it made sense to use it. Why didn't they use estradiol? They wanted to use something that was clinically relevant, that physicians would actually prescribe. Estradiol was not used. It wasn't commonly used in pharmacological options. So they used what was available in the market, okay? And what they found was, this is where the timing hypothesis, this is something we knew for a long time, that when they looked at the younger patients, so the average age in the study was 63, but there were younger patients and there were older patients. But when they stratified the risks and the benefits based on age, what they clearly found was that in women in the study, before the age of 60, or within 10 years of their final menstrual period, of their menopause, they saw that the benefits outweighed the risks, certainly, and for cardiovascular disease. They did see in that group that the all-cause mortality was decreased versus the placebo group, so death from any cause. And they did see that they had a lower chance of heart attack if they started young enough. So what we need now is a randomized controlled study just looking at these younger patients with the modern formulations. That's what we need to be able to clearly say
hormones.
with estradiol and progesterone, or just estradiol if she doesn't have a uterus, or with a Mirena IUD. We have a lot more options now. So, but what people in the know tell me is that those studies are never going to happen, that estradiol is cheap. And, unless the NIH funds it, which the funding is dried up quite a bit during this administration, that we're just not in the right political, politics is who decides who pays for funding from government institutions. We're just not there yet right now to be able to fund such a study. But I'm not giving up.
No.
I feel like we have an opportunity to get women motivated and galvanized now that we've got this black box warning off. There's a lot more attention. Women are talking about menopause. There's a lot more interest. There's a lot more funding from private sources going into this kind of research. So I'm not giving up.
No. And look, you can confer some form of data from observational data, right?
So that's how I counsel my patients. From observational data, this is what we see. Can I promise this for you? Absolutely not.
No.
But I know it's not going to be harmful if you're in this window. And it might be protective at best. Now, what we do know it protects for, that it's FDA approved for, even though the U.S. Preventative Services Task Force is not caught up, is prevention of osteoporosis. Clearly,
correct, yes.
We can prevent osteoporosis. That is clear. There's no arguing that data. If we start a patient, we can prevent her about 50% chance of having an osteoporotic fracture with age, as long as she stays on it.
Well, we've got the KEEP study. Mm-hmm. We've got the WIMS study. Like we've got 3 beautiful studies that actually correlate to lower osteoporotic events, and taking a woman who's actually been diagnosed with osteoporosis to normal bone mineral density in the matter of like 12 weeks.
So when I'm counseling my patients and they're talking about potential prevention, I'm really focusing on the bone health benefits and what that could do for her and what the actual data is showing. If we don't do anything, lifestyle is very important here. So if you just stay on the course, what the actual risks are down the road, which are huge. 1 in 2 women can expect to have some type of osteoporotic fracture in her lifetime.
That just accelerates all-cause mortality. Yes. So I'm currently doing a systematic review. Okay. So I'm an Alzheimer's disease researcher, and I'm now tasked with trying to understand the difference between and this is related to brain health and dementia and Alzheimer's disease. Are we seeing across the board, when we look at all the studies, mainly human randomized controlled trials, are we seeing that hormone replacement therapy is actually the cause of lower dementia incidence? Or is it the fact that it's fixing the vasomotor symptoms associated with perimenopause? And what we don't have is we don't have the data. So I'm right now, I don't know, I'm very much I'm very much, pro HRT. I see it, especially given my area of expertise. Mm-hmm. But I'm Switzerland in trying to understand, is it the vasomotor symptoms that's helping an individual, or is it the hormone replacement therapy? And even if it is, I still stand with hormone replacement therapy being a really great adjunct to lifestyle interventions.
Yeah.
But look, if you're fixing the vasomotor symptoms, insomnia, that's going to help brain health, mental health, that, depression is huge, as you mentioned, hot flashes, yes. Brain fog, another thing. So
have you looked into the care, the Welcome?
Yes, Dr. Lisa
Mosconi's work.
Yeah.
So, talking to her, when she started getting into there was no model to even study estrogen's effects in the brain. She had no tracer to track estrogen in the brain. She had to make one, and that took years. Mm-hmm. And so there's so much opportunity here for us to learn.
There is.
And there is interest now. And now private donations are coming and pouring in to study this. So I'm so curious to see what you find.
Oh, I can't wait. I'm so curious as well now, particularly because I'm now really veering into female health and trying to really understand why 70% of all Alzheimer's disease cases are women. And we have a strong prediction that it's because a lot of the risk factors associated seem to peak during midlife. If you care about brain health, then you can't just think about what you eat. You have to think about what you breathe. Most cleaning products release volatile compounds that act as neurotoxins. This is why I switched to Branch Basics, because I wanted a cleaner environment for both my home and my brain. Their concentrate replaces every cleaner in your house. No synthetic fragrance, no endocrine disruptors, just clean plant-based ingredients. Now, I use this for everything, the countertops, the laundry, even the floors, especially my kitchen. And it's crazy how much lighter my home feels without that chemical fog in the air. You guys need to go and try this. branchbasics.com. Use code NEURO to get 15% off their premium starter kit. Guys, I'm so bullish on this area of my life and trying to remove all of the toxins in my environment. And this is a really great way to start. branchbasics.com. Use code NEURO. I've talked about recovery, travel, and movement, but here's something that most people literally forget about: your feet. And I'm talking about what shoes are you wearing and what socks are you wearing? Because, guys, I've been wearing hollow socks, and honestly, they've changed how my legs feel after long flights or heavy training days. They're like compression socks, if you will. They're really, really long, but they are made from baby alpaca fiber. So they're lightweight, super soft, and way more breathable than anything synthetic. The compression is graduated, which means it supports circulation without that painful squeeze. I can wear them for hours and my legs feel fresher, lighter, and more recovered. Sometimes, I know this is crazy, but I lay down on the floor at home and I put my legs up on a wall for like 10 minutes. I've got to tell you, it is so good for circulation. So if you're on your feet all day, or you're training super hard, or you're traveling often, you'll notice a difference in these. For a limited time, Hollow Socks is running a buy 3, get 3 free sale. Head to hollowsocks.com to check it out. That's hollowsocks.com for up to 50% off.
What you guys say is, and I'm not an Alzheimer's specialist, is Alzheimer's is a disease with symptoms at the end of life. That starts in midlife.
Oh, yeah. And the data is just, and we do take Lisa's work into consideration with the the drop in glucose metabolism in the brain, bring energy metabolism.
Shall we talk about the brain eating itself?
Well, I don't want to say that just yet, but there's been some notable doctors, who put us out, who actually also said that the brain consumes itself. And I think, you've got over 3 million followers. How hard is it to get on and really push out this information?
Sound bites are sound bites.
Yeah.
And I've seen several esteemed colleagues have quotes taken out of context or just a little snippet, and the internet goes wild. Look at the biggest one for me was when Rachel Rubin talked about the labia.
Yes.
Majora kind of
atrophy.
Yeah. And so I wrote a Substack about it. And then when I went to Ask the Public, so that's a website where you can see what's trending on the internet. So I get curious sometimes. Mm-hmm. And so I type in menopause, and the number one after weight gain was the labial atrophy question.
Oh.
And I'm like, wow, all the things that women are concerned about, this was the hottest trending thing was the appearance of the labia. And of course, there's functional things as well. But so I wrote a Substack and it went viral, where I was just explaining the science behind it and what you can do. So little vaginal estrogen goes a long way to maintaining the architecture of the area. It was just crazy what the internet is going to jump on. So I always take a deep breath and calm down. And so when I saw that clip go viral on the brain eating itself, I thought, I watched the testimony where they talked. So let's talk about the science for your listeners of the demyelinization. So you're the brain researcher.
So I can definitely talk about that. So the brain has around 87 billion neurons, and every neuron has around 15,000 connections. At birth, it's 3,000. As we do new things, it forms new connections, and it's a beautiful thing. And along the axon, we have, it's like the leg, I would say, of the neuron. We have this thing called the myelin sheath, okay? And it's made of fatty oligodendrocytes. It's a type of brain cell. And this is what helps us with conduction speed.
It's the insulator.
It's in the insulator.
It's like the plastic around the cords of your charger.
What I've done a lot of are electromyographies, where we're picking up on MS, for example. And what we'd see is slow conduction velocity. That would mean that the myelin sheath is breaking a part of that, or it's thinning. But it turns out that the primary fuel source for the brain is glucose. We know that, right? And as Lisa Mosconi's research has shown, what we go through during perimenopause and postmenopausal women, we see a reduction in brain glucose metabolism. That means that the brain cell itself cannot uptake glucose the same way it would in your 20s.
And is that directly related to the estrogen receptor?
Well, yes and no. Okay. There is, we believe that yes, it is, because the estrogen receptor can't shuttle in. It's no longer functional because there's no estrogen. So it can't shuttle in glucose as well as what it used to efficiently. So then the brain cell is like, okay, I need energy because it's a hungry organ. It needs energy to survive. It's the most vascular rich organ in the entire body. It says, well, where am I going to get my energy from? Where am I going to get my fuel from? So because it's so smart, it starts to catabolize the myelin sheath in order to produce ketone bodies to use as fuel.
This is the same thing that happens outside of the brain. When we run out of glucose, which we all do, like when we sleep, the body will switch to burning fat for fuel. That's a natural process, when we're not giving it continuous glucose. So it just makes sense.
It does make sense. And that's what, Dr. Roberta Brinton said she didn't use the word eat itself.
No.
She used the word catabolize, but there's other prominent neurologists have said that the brain consumes itself.
But it's temporary.
It's temporary. And so, back to like this N of 1, right? So I split my time as a researcher then in neurosurgery. And we see, there are no randomized control trials on some of the things that we're doing in the surgery. I'm in a specific area, which is neuroplastic neurosurgery, right? So we're doing reconstruction of skulls and we're literally forming a whole new board certification. Well, not me, but my director is. And, he's like, okay, we need to publish this. We need to publish this. So it's like, well, I don't have the data yet. So this just shows you that observationally, this is great because we're seeing it on our post-surgical patients. And I just wish the whole world knew what academic research really involved.
Yeah.
Brain fog I think it's also misunderstood. But why is it so big during perimenopause?
What we know in perimenopause is rather than what I was taught and what I thought I understood was that estrogen went through this slow, gentle decline until menopause when it bottomed out and then you were zero. What I didn't learn until about 3 years ago, and I have to give credit where it's due, Nanette Santoro did this work in 1996. She had women collect urine samples, God bless them, for 6 months every single day. And she tracked metabolites of estrogen and progesterone. She did premenopausal patients, perimenopausal patients, and postmenopausal patients and measured that across the board. And what she found and published that never got widely circulated was that in perimenopause, in premenopause, we have this very predictable ebb and flow month after month after month if you're having normal, regular cycles. It almost looks like an EKG. On day 14, your estrogen does this. On day 21, your progesterone does this. And it makes this very reproducible, predictable curve. In perimenopause, we go into chaos because ovulation begins in the brain, not in the ovaries. The ovaries just do what they're told. So when we reach a critical egg threshold level, the signals coming from the brain that used to simulate an ovulation each month don't work. So the brain doesn't get the feedback of the estrogen level rising like it used to. It can't. It needs more. So the hypothalamus is like, hey, where's my estrogen? Talks to the pituitary, says, hey, pituitary goes, boss, I sent down the signals. I sent down my FSH and my LH. And they said, send more. So we see these much higher levels of FSH that kind of force these ovulations. The timing becomes off. We see surges of estradiol higher than we've ever had in our entire life. Then we see crashes. We see delays in progesterone, never can quite keep up. And this chaotic pattern can go 7 to 10 years before the final menstrual period, before you run out of eggs. And so that is where we realize there's chaos in our hormones, and that chaos feeds back directly to the brain. Not only is the brain not getting that regular ebb and flow, and for some women, we have cyclical, understandable fluctuations in our mood and in our brain function, and we're seeing it athletically as well.
Yes.
And so tying to our cycle, imagine in perimenopause, my toughest patients were my perimenopausal athletes who were competing in triathlons at higher levels, who were like, I can't function like I used to anymore. Or my lawyers, my people who are using so much cognitive function, at work, who are completely struggling. So that's kind of where I started seeing the patterns, was in perimenopause. Things really calm down and we rewire the brain after menopause, but it's peri where we see the biggest drama.
Yeah, I have a friend, she's 42, about to be 43, and she messaged me, she's like, oh, I'm late, I haven't had my period for 2 weeks, not pregnant. And she's also experiencing that. She's like, I'm waking up at night and I'm boiling hot. I'm like, hi. I said, do you listen? You're one of my best friends. Do you listen to my podcast? I said, I think maybe you're in perimenopause. Maybe you need to go and speak to somebody about it.
Yeah.
But let me tell you, her mother, irrespective of the BRCA gene, did have breast cancer. She's fine now. So she's petrified. And that's the first thing she said to me. She goes, I'm not doing that. I'll get breast cancer.
What we know is that women on estrogen only from the WHI had a 30% decrease relative risk of breast cancer versus placebo. It was only the women who were taking the combination, and it wasn't even statistically significant increase. It never reached
1 in 10,000, wasn't it?
Out of versus baseline.
Yes.
So every woman has a risk of breast cancer. We have breasts. Men have a risk of breast cancer. But then we take out the baseline, it was only 1 extra case per 1,000 per year. And again, everything we take, every aspirin, every Tylenol has its own particular risks and benefits. And so that's how I counsel my patients. This isn't HRT for everyone. This is nuance. This is precision. This is talking to her about her goals, her needs, and what we think it might be able to help her with.
Back to the brain fog, it's this feeling in the front of your head where you feel all cloudy. I know you mentioned like the hypothalamus and the regular periods, but do you think it's also due to the fact that they're not getting into deep sleep, not activating the lymphatic system and
the lymphatic system? Yeah. So lots of great sleep research coming out across the transition. I wear one of these trackers. Lots of women are wearing trackers. And anecdotally, that data is being collected. And so when the neuro researchers are looking at it and and they're also putting in their menstrual history, there's a lot of patterns coming up where we're seeing loss of deep sleep. We're not clearing out those proteins through the lymphatic system. We need a lot more research here, but the observational data is showing a correlation. I mean, I really focus on sleep with my patients.
Oh, wow.
So I'm like, sleep is number one.
Yeah.
For heart health, for brain health, for mental health. If you're not sleeping, we've got to start here and focus.
I don't know if you've seen this, but you might like this for your patients. There's new human data out that shows that you can activate the lymphatic system as well through just here. If you were to massage your face, I can send you the data. It's
oh my
wonderful.
God, I want to see it.
I'm going to do a reel on it. We've had Dr. Kellyanne Niotis on the podcast, and she's also mentioned this as well. And so she's getting her patients to actually do this form of lymphatic drainage on their faces to
Amazing.
activate it.
I'd love to see it.
Which can actually eliminate amyloid beta.
Wow.
Yeah. Do you have patients coming in with cognitive deficits?
Mm-hmm. I mean, I'm not measuring them, so we're not doing the cognitive testing. They're coming in complaining of brain fog, difficulty functioning at work. The data out of I think it was the UK, 1 in 5 to 1 in 10 women are quitting their jobs in menopause because they don't feel like they can complete their jobs. Now, some women quit their job because they hate their job, and menopause does this wonderful thing where we can finally circle the wagons and put ourselves first.
Like the We Do Not Care Club?
The We Do Not Care Club. Like, look, this job is not serving me. I'm better off not having this particular position. But these are my patients coming in who love their jobs, who are thriving in their jobs, who are ready to lean into this, their wisdom and their leadership. And they are struggling because of cognitive deficits at work. So these are the patients where I'm really trying to help them figure that out.
Part of my routine of eliminating toxins for better brain health and overall longevity is about removing the toxic burden that I place on my body. And one of the smartest things I've done is switched all my makeup and all my skincare products. You know how I always say that your brain and your body are connected? Well, your skin is a part of that story. When your skin barrier is strong and inflammation is low, it shows. That's exactly why I changed all of my products to Jones Road Beauty. Their daily moisturizer and face wash are simple, clean, and support skin health without the harsh chemicals or fillers. That's right. No fillers. It's skincare that actually respects your biology. I use them after training or when I'm traveling. I actually use them 24/7. I don't use any other product. If you want to look at this, even if you want to look at the ingredients list, you can go to jonesroadbeauty.com, use code NEURO. You will get money off and you'll get this free gloss with your first purchase. Just go on their website, have a look at the ingredients, have a look at what they offer, try it out, try the face wash out because you won't be sorry. I've become more bullish on testosterone. We've got our own approved testosterone for women in Australia. Here, it's not but off-label. You can prescribe it.
We have great data for sexual function.
Yeah. For sexual function, yes. But the data on women feeling like themselves again, like motivated to go back to work, invigorated is fantastic.
I'm seeing that clinically, but I'm not making claims to my patients that this is going to turn your life around. I might share a patient anecdote or something, and I'll be like, let me know if you're noticing other aspects of your life that are improving. But I really focus on for them if they have sexual dysfunction, where it might be helpful for them.
I think I heard you mentioned or someone mentioned that the divorce rate seems to skyrocket in menopause.
So the gray divorce is, and it's funny, those are another viral video on social media whenever I talk about divorce. So this all started, I have a patient who is a divorce attorney. And she came to see me and we were just chatting in clinic. And she said, she was from the South and had this cute little accent. I think part of my patients are divorcing because of menopause. And I said, really? Why? And she said, the untreated genital urinary syndrome of menopause, and that they're feeling kind of forced to perform and they're having pain and no one's addressing it. And when they go through the divorce proceedings, it comes out that they felt abused, physically, and that, that was a huge contributing factor to their marriage ending. And they want their pound of flesh back.
Oh gosh.
In the divorce. And so I was like, wow, reeling from this, And I talked about it on social media, and there was really two camps. It was women saying, yes, yes, yes. Like menopause changed me, and therefore my husband couldn't relate to me anymore, and he left me. The other half of women felt very strongly that it gave them permission to leave a marriage that wasn't serving them. So it was very, very stark, the divide of like, no, he was an asshole, and menopause gave me the power to leave, And the other half were like, it destroyed my marriage.
What is the urinary?
Genital. Great question.
Yeah.
Thank you for asking. Genital urinary syndrome of menopause. You'll hear it. It's also been called senile vagina.
Okay.
Horrible term. It's been called vaginal atrophy. So basically, our tissues in the urethra, the tube that drains the bladder, the tube of the vagina, and the labia, the whole genital urinary system, from the pubic bone basically all the way back to the anus. All right, exquisitely sensitive to estrogen levels. So when those estrogen levels decline, we see the tissue of the labia majora, labia minora, bladder, urethra, vagina thinning, losing elasticity, losing its ability to produce mucus, therefore lubrication, also losing the microbiome changes, therefore making us all of that makes us more prone to urinary tract infections.
Okay.
So women come in with a very beat up, bruised, genital urinary system. They can't tolerate intercourse. It's absolutely horrible. Their doctor says use some, lubricants can be helpful here, but they're not fixing the root cause. And everyone's terrified of estrogen and don't understand the nuances between vaginal, and even doctors, between vaginal estrogen and systemic. And these women aren't getting properly treated for something that almost all women are going to have some degree of. And it is contributing to the lack of intimacy, which starts eroding away at a marriage.
Have you heard of PRP and vaginal rejuvenation? So Kim Kardashian's on this new TV show with Naomi Watts.
Naomi Watts.
Because we just met Naomi at her event that she had here, and God love her.
All's fair.
All's fair, yeah.
I haven't seen it yet. I just watched the clips.
So there is this scene in the second episode, right, where Kim is saying she's doing things for herself. She just got a divorce, and she's like, I went and had PRP rejuvenation. She got PRP into her vagina. She's like, now it's big. It's fluffy. It's back to what it was when I was 20. And then Naomi Watts is bringing up NAD as the holy grail for inflammation during menopause. And I'm like, firstly, NAD, no. They also said NAD. And I just feel like there's just so much marketing around menopause right now, spotlighted and now on the big screen on Hulu.
Wow.
Yeah. And I thought, PRP.
I don't know who they did the research.
I don't know who did the research, because they actually didn't even, they said NAD.
When we talk about longevity for women, and when we talk about what happens to the body in menopause, when we look at all of these, gadgets, the red light therapy, the cold plunges, the sauna, if you are not eating a plant-focused, protein-rich diet, if you are not sleeping at least, 8 to 9 hours at night, if you are not managing your stress, none of that is going to be helpful. Like, we have to get back to the basics here. That stuff is like the sprinkles on the top of the cake. And the data is, not great for women. And we're basically packaging all this done on mostly young male athletes and saying, here you go, menopausal woman.
Yes.
Now, for the rejuvenation of the vagina, there's, this is misogyny, this is patriarchy, this is, but also female empowerment. What if you want your vagina to be fluffy and all those things? You have the right to be able to do that. But the evidence is not great. The best thing you can do for all vaginas need estrogen. All of them. And it's healthier with it. So if you're not doing estrogen first in the vagina, doesn't matter the PRP and all the things and the lasers, none of that is necessary. Vaginal estrogen is safe, efficacious, and it's going to work almost 100% of the time.
Oh my gosh. I love that. No NAD is going to make your vagina bigger more so than estrogen.
More fluffy.
More fluffy. Okay. You wouldn't describe it as the miracle, right? Because during my early 30s, when I was doing all this research, I was like, okay, the holy grail here is actually weightlifting.
Well, what are we looking at? What are your goals? When we talk about weightlifting, if you're talking about osteoporosis prevention, frailty prevention, diabetes prevention, strength training and maintaining your muscle mass is probably one of the best things you can do.
What do you say to a woman who says to you, I want to do this all without hormone replacement therapy?
Great. Okay. First of all, I ask why. Like, is this a decision based on facts and not fear? And if we have that discussion and she's still like, I'm not interested, that's her right. I'm totally down. Not all my patients choose hormone therapy.
What if she says, because this is what I received, like there was a reel of mine, as we mentioned, went viral. There's around 8,000 comments. And I was like reading through them and they're like, yeah, but hormone replacement therapy, our grandmothers lived to 90 and they didn't take HRT and they were fine.
Maybe your grandmother lived to 90. But when we look, we haven't lived as a population. When we look at population science, it's only in the last 50 to 75 years that women have really significantly outlived menopause as a population. So we have artificially extended our lives with good nutrition, with vaccines, with plumbing, with, the things that killed people. They weren't dying of heart attacks. They were dying of saber-toothed tigers eating them. They were dying of not having access to antibiotics. They were dying of infections. So now we've kind of fixed a lot of that. And we have people living 30 years without the benefits of their estrogen. So this is really kind of a new time where we're seeing a 51% of the population living without the benefit of their hormones. Now, replacing those hormones, how much of that is that going to extend their health span and their lifespan? We're not sure because we experimented with it for about 20 years and then we took it away. So we don't know how much of that is going to really improve. We know it's going to decrease our risk of osteoporosis and fracture. And that is a huge cause of disability.
Extend life.
Yeah. And, most of my patients don't want to live to 120. They don't care if they die at 100.
No.
They're not in this to be shirtless on the cover of Vogue, like some of the science bros. They're not interested in that.
No.
They just don't want to be a burden on their families as they age. They want to live as independently as long as possible. And that looks very different than what most of the men I see on the internet talking about this. And so talking about, longevity, they want to be able to love their loved ones, take care of themselves, and live a pretty pain-free life.
And remember their daughters' names and some of the experiences that they had throughout their life.
So how much HRT can be helpful for that? We don't know yet.
Yeah, I think one of the beautiful things that I've learned from you is that women's healthcare is political because it has to be, because we have to set policies. But as Dr. von der Wright says, a woman in care is apolitical, and she should have the choice to be on hormone replacement therapy if she feels it's best suited for her or not.
Or not.
Exactly.
Yeah. So what I tell these patients who are like, you know what, it's not for me, I don't want to do it, not everyone tolerates it, is, okay, we really have to double down on all the lifestyle factors. And then we treat each symptom accordingly. But we have non-hormonal options for hot flashes. So like you said, how much of dementia is the neurokinin receptor versus the loss of estrogen, right? The hot flashes contributing to loss. So is Veoza, are those type of drugs, the neurokinin agonists, going to be a player in decreasing the rates of dementia? These drugs just came out. We don't know yet.
I think the only thing that's misunderstood still is 45-year-old woman comes to you, cycles still every 28 to 30 days. She's having all the vasomotor symptoms, but your
I would start her on estrogen.
TSH is fine. Estrogen, progesterone, 1-to-1 ratio, everything's fine blood work wise. Even if you do a timestamp and do her blood work every single day for 5 days, blood work seems fine.
We do a trial and see if she gets better.
And there's nothing wrong with that.
Low dose. Yeah. It won't suppress her ovulation. If we do a low dose estradiol patch or something.
Why would it suppress her ovulation?
It's not high enough dose to suppress the ovulation. So she's still going to have her normal, cycling in the background. But what we do is take out some of the chaos. We're going to stabilize things a little bit so the brain is not looking for that estrogen.
Can a woman still fall pregnant on hormone replacement therapy?
Yes, absolutely. So if contraception's an I always address that first. What are you using for contraception? We have to get this addressed.
Yeah.
So a birth control pill might be an option for a perimenopausal patient. Because she also needs contraception. If she's having cycle irregularity where her cycles are super heavy, a birth control pill might be an option for her as well.
Yeah, I'm seeing so many women actually message me saying, I'm perimenopausal. I had struggled to fall pregnant. She goes, now that I've fixed my hormones and I'm 43, She goes, I felt pregnant. I'm like,
Mhm.
good for you. That's amazing. We're going to finish off now. I mean, I wish I could I don't even know where we went with the podcast. I've got all these notes here. If you guys are following on YouTube, I don't know I didn't even look at them, but I love what you're doing. Where do you see this whole sphere menopause going in the next 10 years?
I think that women are aware of it. They're talking about perimenopause. The boomers are pissed. The Gen Xers are not standing for this. The millennials and all the kids coming up behind us, it's becoming part of their vocabulary. They're learning. They're not afraid. They are wanting to get ahead of it. I have more and more patients coming in at younger ages, just wanting to get educated and get ahead of this so that they can transition as well as possible. What they don't want is to be blindsided like our generation, our mother's generations were.
Oh, I love that. Well, Dr. Mary Claire, thank you so much for coming on the podcast.
So happy to be here.